This education will be focusing on Section GG, Functional Abilities and Goals. It is a large part of how the federal government determines the quality of care a resident receives. We need to ensure all staff understand how to complete the coding for this area. Let's review the learning objectives. The learning objectives for this education are to review the sections of the dataset, understand what usual performance means, learn when to complete the items for the MDS process, understand what the correct coding is, Let's look at the first few items, section GG 100, 110, 115, and 120. The prior functioning section in GG 100 reviews where the resident was prior to the current illness. The items are more general than the questions later in the dataset. It reviews self-care such as bathing, dressing, eating, and using the toilet, indoor mobility, including walking room to room in their previous environment, how they use the internal or external stairs in their previous environment, and their ability to plan for normal tasks, such as shopping and taking medications. The coding for this section is broader, as well as being only a 3-point scale. 3 is independent, 2 needing some help, 1 dependent. There are 2 other responses for unknown or not applicable. Use the unknown code if you cannot determine the response due to resident's inability to respond. Use the not applicable code if the resident did not complete the task prior to their illness. The prior device use section asks what devices the resident needed to move around prior to their current illness. It is a check all that apply question with the typical responses of wheelchair, motorized wheelchair, mechanical lift, walker, and orthotic or prosthetic. Functional limitation in range of motion are the same questions that were previously in Section G. They ask if the resident has any limitations that cause them to have difficulty with providing their own care in both upper and lower extremities. Use the actual self-care and mobility activities we will discuss later as examples of functional limitation. The mobility devices differ from the prior device use question because these are the devices being used while in your facility. For example, a resident who did not use a wheelchair while at home, but may be using one while in your facility due to a hip fracture. Now let's look at the definition for usual performance and the time frames of completion of the information. Coding usual performance ensures that you are looking at the whole picture, unlike the previous process for Section GG, where you focused your coding on the most dependent no matter when it was during the time frame and what they called the rule of 3. This coding allows for better picture of the resident because you are making a qualified decision as to what the usual performance of the resident is for that time frame. If their ability varies throughout the day or shift, how did they perform it the most? When interviewing the staff that assist the resident with care, ask what they did and how they did it across the entire shift. This will help you code more accurately. When coding for usual performance, you need to keep the helper in mind as well. A helper is a staff member hired by the community and is considered part of the community's direct care staff. This can be a nurse aide, therapist, or any other staff member, including an agency member, that is not a hospice worker or other non-facility contracted person. If the resident's family or any of these other types of people, other than a direct care staff member, provides the service, you cannot consider their assistance. Ask the staff on each shift what they provided for the resident. Use probing questions that will determine the best possible responses from that individual. Each shift should have a licensed staff member who has been trained properly in how to complete the areas in Section GG. You can use the user-defined assessments in any electronic health record if they are available to assist in gathering the information on each shift. With this information in place, it will allow you to have a comprehensive review of the resident's performance. The admission performance should be completed by day 3 of the admission. This is the only time on an MDS that the assessment reference date, or ARD, is not the limiting aspect of the item set. Make sure that you take into consideration the areas discussed previously. Therapy may have completed Section GG items as part of their evaluation, but the clinical team should also be completing these items since it is to be based on a resident's performance before any improvement by therapy. All items should be coded or assessed based on the resident's status before therapy begins to collaborate with them or before improvement is shown in therapy. Again, discuss this as an interdisciplinary team to ensure that this is known. Unlike the admission performance, this assessment timeframe is based on the assessment reference date plus the 2 previous days. It is coded just like the admission performance, except now any improvement by therapy should be noted as part of the process. If this type of MDS is being completed and therapy is still providing treatment, ensure that therapy completes another evaluation of Section GG areas to allow their voice to be heard as part of the interdisciplinary process. This type also holds true for the standard OBRA types of assessments such as quarterlies, annuals, and significant changes. This type of performance is based on the assessment reference date plus the 2 previous days as well, but this time the ARD is the date of discharge from Part A or from the community. Make sure that your coding is accurate. The more improvements seen, the better it is for the resident overall. Now let's look at the actual activities themselves so that we understand what each means. How do you code Section GG? We have spoken briefly about not attempted codes, but now let's learn how to code the specific activities. For those of you who have completed the coding for Section G in the past, you will remember that the higher the code, the more assistance the resident required. It is exactly the opposite for Section GG coding. Six is the code for independence. It is just like it says. The resident can complete the entire task with no assistance. 5 is the code for setup or cleanup assistance. The helper provides only assistance with setting up and/or cleaning up before and/or after the task, but the resident can complete the actual task on their own. An example of this would be if the resident needs help opening containers, cutting up food, etc., but can eat without assistance. 4 is the code for supervision or touching assistance. Use this code if the resident requires cueing, contact guard, guiding, or supervision while performing the task. An example for the coding of supervision would be if the resident is capable of performing the task but may become confused or tired and requires reminders to finish it. Another example would be supervision due to safety concerns while walking. 3 is the code for partial assistance. This code is used when the helper helps with less than half of the effort during the task. For example, the resident eats most of their meal but requires assistance to finish the last few bites. 2 is the code for substantial or maximal assistance. Use this code if the helper provides more than half the effort during the task. For example, a resident can adjust their own clothes after using the toilet, but cannot clean themselves or place the brief or pad in place. One is the code for dependent. Using this code means the resident cannot provide any assistance with the task, or the task requires two helpers to complete with the resident. A good example of this would be a resident requires a full mechanical lift for transfers. There are several different types of activity did not occur codes. They are 7. Resident refused, if the resident refuses to complete the activity. 9. Not applicable, if the activity was not attempted and the resident did not perform this activity prior to the current illness, exacerbation, or injury. Code 10, not attempted due to environmental limitations, if the resident did not attempt the activity due to the environmental limitations. Examples include lack of equipment or weather constraints. And lastly, use code 88, not attempted due to medical conditions or safety concerns, if the activity was not attempted due to the fact that the resident had a medical condition or safety concerns that prevented them to complete it. CMS has provided a decision tree to assist with coding. Using the decision tree is easy, and this can be printed out to use as a reference until you are comfortable with the process. Coding considerations to remember. All codes are based on the resident's current performance and not what they were able to do in the past or what the staff believe the resident can do now. Any time that two or more helpers are needed, you should code the item as a 1 for dependent. If the activity was not attempted, code the resident either as a 7, 9, 10, or 88. Use the dash only if no other code can be used. Do not leave any area blank. Place a code in that item that matches as closely as possible. Now let's review these specific items for section GG. In this section of the education, we will review each item set with its definition and any clarifications that have been added to the Resident Assessment Instrument, or RAI manual, as of version 1.18.11, the one that will go into effect October 1st of 2023. If this is a resident that has been admitted for short-term rehab, you should encourage them to perform the activities themselves, unless they cannot perform them on their own. If they did not complete the activity before admission, then most likely they will not be able to do so now. Ask their family members to determine what the resident can or cannot do. Ask if there are any safety concerns that need to be addressed. You do not want to encourage the resident to do more than they are capable of. If the staff need to provide an assistive device for the activity to be completed, code that as part of their process. As stated before, try not to use the dash or leave the item blank unless you truly have no choice. The exception to this rule is for the discharge goals, where only one or a few of them need to be coded. The rest can be dashed. When we go through the example at the end of this education, we will show you that. CMS expects the dash and the blank to be used sparingly. As we discuss these activity items, we will speak about some of the not attempted codes. Always consider that the resident should be allowed to perform the items as independently as possible. This gives you the most accurate picture of their performance. The self-care items are based on definitions of care the resident provides for their own physical health. All items are hygiene, care, or dressing related. Eating. How the resident eats. If the resident does not due to a tube feeding or other reason, code this area as 88. not attempted due to medical condition or safety concern. Oral hygiene, the resident's ability to clean their teeth and dentures. Can they remove them, clean them, place them back in their mouth, use the toothbrush, etc.? Toileting hygiene, how the resident provides their own cleaning of their perineal area as well as how they manage their clothes while doing this. This includes ostomy care of the area, but not replacing the device if it is needed. Showering and bathing self. Like bathing in Section G, this area is based on the bathing event except washing the resident's hair and or back. It does not include the transferring into or out of the tub or shower. It is only the washing. Dressing is broken down into the upper and lower body as well as footwear. This is completely different than Section G. Upper body dressing includes the actual articles of clothing or devices that the resident uses, but not a hospital gown. Putting on and taking off of a hospital gown is not enough to determine the resident's ability. If the staff help with buttons or any other type of fasteners only, this is considered touching assistance. Lower body dressing. The same for the lower body. Fasteners only is considered touching assistance. The lower body dressing includes typical articles of clothing as well as knee braces, limb prostheses, etc. It does not include footwear. That is in the next activity. Putting on, taking off footwear. Footwear is considered anything that goes on the foot, socks, shoes, sneakers, etc. It also includes ankle braces, compression stockings, etc. Personal hygiene. This is like Section G's personal hygiene. It asks about the resident's ability to provide personal care, including combing the hair, shaving, applying makeup, washing and drying their face and hands, but it excludes baths, showers, and oral hygiene, which are located in other activities. The mobility items show the resident's ability to be mobile, either in bed, transferring, walking, taking stairs, or using a mobility device such as a wheelchair. CMS does not provide an exhaustive list of assistive devices that may be used when coding self-care and mobility activities. Clinical assessments may include any device or equipment that the resident can use to allow them to safely complete the task or activity as independently as possible. Do not code self-care and mobility activities with the use of a device that is restricted to a resident's use only during therapy sessions, such as parallel bars. Rolling left and right. This one is exactly how it is stated. How the resident rolls back and forth in the bed, from left to right. There are considerations to this as well as the other bed mobility areas. Good clinical judgment should be used. If the resident cannot lie flat in bed, you cannot get them as low as possible and allow them to roll, or if this is not possible, code 88, not attempted due to medical condition or safety concern. If this is coded, then investigate further. This may mean the resident cannot lie flat due to shortness of breath, and this should be coded on the MDS. Sit to lying. Have the resident sit on the side of the bed and then have them go from sitting to lying down. Again, if they cannot lie flat, then you need to code 88. Lying to sitting. This is the exact opposite of the last item. These two items are split into separate areas because a resident may be able to do one well, but not the other. This allows you to focus on the one that they cannot do as part of the plan of care. If the qualified clinician determines that bed mobility cannot be assessed because the degree to which the head of the bed must be elevated because of a medical condition such as COPD or asthma, then code the activities for GG 170A, roll left and right, 170B, sit to lying, and 170C, lying sitting on the side of the bed, as 88, not attempted due to medical condition or safety concern. Sit to stand. How the resident comes to a standing position. If they use assistive devices, make sure these are in place. If they need a mechanical lift, code them as a 1 dependent. Chair, bed to chair transfer. How the resident transfers to from a bed or chair. The item begins with the resident sitting upright in one location and then ends with them sitting upright in another one. Again, if they require full mechanical lift, code them as a 1 dependent. Toilet transfers. How the resident gets on and off the toilet. This is for toilet bedside commode transfers only. This does not include a bedpan or a fracture pan, etc. Tub shower transfers involves the ability to get into and out of the tub or shower. Do not include washing, rinsing, drying, or any other bathing activities in this item. If the resident does not get into or out of a tub and/or shower during the observation period, use one of the activity not attempted codes such as 7, 9, 10, or 88. Car transfers. These are not a typical clinical aspect unless the resident goes out of the community on a doctor's appointment or for a ride with their family, etc. Do not code this one with a dash or leave it blank. You would code this as a 10, not attempted due to environmental limitations. This may also be an area that therapy provides as part of the evaluation and should be coded with their assistance. The walking items start with the resident in a standing position. A walking activity cannot be completed without some level of resident participation that allows resident ambulation to occur for the entire stated distance. A helper cannot complete a walking activity for a resident. During a walking activity, a resident may need to take a brief standing rest break. If the resident needs to sit to rest during a GG walking activity, consider the resident unable to complete the walking activity and use the appropriate activity not attempted code. Clinicians can use clinical judgment to determine how the actual resident assessment of walking is conducted. If a clinician chooses to combine the assessment of multiple walking activities, the clinician should use clinical judgment to determine the type and amount of assistance needed for each individual activity. Walking activities do not need to occur during one session. Allowing a resident to rest between activities or completing activities at different times during the day or on different days may facilitate completion of the activities. When coding GG 170 walking items, do not consider the resident's mobility performance when using a parallel bars. Parallel bars are not a portable assistive device. If safe, assess and code walking using a portable walking device. Walk 10 feet. If the resident does not walk, code for the appropriate activity, not attempted code, and skip to the one-step curb item. Walk 50 feet with 2 turns. If the resident is in an isolation situation, this may be completed using their broom and walking around it several times, or any other idea that the helpers may have. Make sure that they use any assistive devices the resident normally uses. Walking 150 feet. This may be difficult to attempt if the resident is in isolation. If you can determine this, then do so. If not, code the resident as 88, not attempted due to medical condition or safety concern. We do not want to place the resident or any other residents or staff at risk. Walk 10 feet on uneven surfaces. How the resident walks over uneven surfaces, either inside or outside. An inside courtyard is a good place to attempt this, as well as outside on the sidewalk. You may even have some type of obstacle course created. Whatever will work and is still safe for the resident. Completing the stair activities indicates that a resident goes up and down the stairs by any safe means, with or without any assistive devices, for example, railing or a stair lift, and with or without some level of assistance. Getting to and from the stairs is not included when coding the curb or step activities. Ascending and descending stairs does not have to occur sequentially or during one session. If the assessment is of going up the stairs and then down the stairs occurs sequentially, the resident may take a standing or seated rest break between ascending and descending the 4 steps or 12 steps. If a resident requires a helper to provide total assistance, for example, the resident requires total assist from a helper to move up and down over a curb in their wheelchair, code a 1 dependent. A resident who uses a wheelchair may be assessed going up and down stairs, including 1 step or curb, in a wheelchair. Code based on the type and amount of assistance required from the helper. If at any time of the assessment a resident is unable to complete the activity because of a physician prescribed restriction, for instance, no climbing for 2 weeks, but could perform this activity prior to the current illness, exacerbation, or injury, code 88 not attempted due to medical condition or safety concern. 1 step or curb. How the resident can step up on either a curb or just 1 step. This can be simulated in most therapy gyms or by using a stable step that can be brought into the resident's room. Make sure the step is the same height as a standard curb or staircase step. The typical stair is 6 to 7 inches tall. How the resident goes up and down 4 steps. This is actually done in a therapy gym, or if your community has a stairwell, you can take them to that. Do not attempt this on your own. At least 2 staff members should be there to be prepared for any situation. If you cannot attempt code 88, not attempted due to medical condition or safety concern. How the resident goes up and down 12 steps. If they cannot, code appropriately. If a resident's environment does not have 12 steps, the combination of going up and down 4 steps 3 times consecutively in a safe manner is an acceptable alternative to comply with the intention and meet the requirements of this activity. Ensure that you attempt this with all safety in mind. If the resident has poor balance or is unable to do the picking up an object, code 88. If a standing resident is unable to pick up small objects from the floor, therefore requiring the helper to assist in picking up the object, code as a 1, 2, or 3, depending on whether the helper is providing all the effort, more than half the effort, or less than half the effort, respectively. Assistive devices and adaptive equipment may be used, for example, a cane to support standing balance and/or a reacher to pick up the object. GG 170Q, does the resident use a wheelchair and/or scooter? This is a yes/no question. If they do not, you may skip the rest of the questions. If they do, continue to wheel to the next question, which is wheel 50 feet with 2 turns. Once the resident is in a chair or scooter, how do they maneuver? Then state whether it is in a manual or motorized scooter. The last areas in section GG are 170S and 170SS, wheel 150 feet, and whether or not they use a wheelchair or motorized scooter. Again, just like the wheel 50 feet, code them for their level of performance and if they used a manual or motorized wheelchair. A few more things to remember. about coding in section GG. Always keep the resident in mind during the entire discussion. And if their goal is to go home, you should be encouraging them to do as much as possible on their own. Also, any goals that you may choose should be added to the resident's baseline care plan and eventually their comprehensive care plan. Thank you for your time today. If you have any questions, please contact me at bstever@qualityoutcomesmatter.com. Thank you.